So this is the second of the Immunology podcasts, and it's going to be on allergic disorders. In this talk, I'm going to start with some basic definitions and principles. I'm then going to consider the various pathophysiological mechanisms associated with allergy, go on to talk about some of the investigations that are important in the diagnosis of allergy, and then some of the general management principles. Lastly, I'm going to consider some specific types of allergic response, including food allergy, urticaria, and angioedema, specifically associated with C1 inhibitor deficiencies. So firstly, some basic definitions. Allergic disease may be defined as the development of a type 1 hypersensitivity response to environmental allergens, and it includes a wide array of different conditions. Just going through them, these include emergency conditions such as anaphylaxis, as well as non-emergency things such as rhinitis, asthma, atopic dermatitis, food allergy, drug allergies, occupational allergies, and toxin allergies such as bee sting. It's important to understand type 1 hypersensitivity, as this mediates all of these conditions. Basically, on first exposure to an antigen, whatever it may be, there is formation of IgE antibodies which fixate to mast cells and basophils. Subsequently, on second exposure to the same antigen, there is the formation of antigen-antibody complex on the surface of the mast cells and basophils, and this results in degranulation, release of mediators and vasoactive substances, and the onset of symptoms. Usually, Ig allergic responses occur within minutes of antigen exposure, but maybe up to 2 hours. This is termed the initial or rapid response. In thinking about the clinical features that occur, it's quite useful to divide this response up into skin changes, such as angioedema, urticaria, and organ system changes, which result due to 3 important things happening. Smooth muscle contraction, resulting in constriction of airway and wheeze, and constriction of gut, resulting in diarrhea and vomiting, excess mucus secretion, further contributing to wheeze and causing rhinoconjunctivitis, and increased vascular permeability, which of course contributes to everything. So as we've already said, this initial phase occurs usually between minutes and up to 2 hours of exposure to the antigen or allergen. However, there is a secondary or delayed phase with onset between 2 and 24 hours after allergen exposure, which may last for many days. This phase is characterized by intense inflammatory cell infiltration and associated tissue damage, and is mediated by a wide variety of mediators that are produced by activated mast cells. Eosinophils are particularly important in this delayed response. So now, some of the investigations in allergic disorders. The most important investigation is skin prick testing, which involves exposure to small amounts of a proposed allergen, and hours later, investigation for the classical wheal and flare response, in which the wheal should be greater than 2 millimeters. Usually this is compared to both positive controls, pure histamine, and negative controls, pure saline. This is the gold standard for allergy investigation, as it is rapid, cheap, sensitive, and specific. There is, however, a small risk of anaphylaxis, and therefore patients with a history of severe anaphylaxis should not undergo this form of testing. Steroids do not have to be stopped before this procedure, but antihistamines should be stopped for at least 48 hours before skin prick testing. The next investigation is the RAST test, which searches for the quantity of specific IgE to a proposed putative allergen. This is less sensitive and specific than skin prick testing, but is a useful alternative if there is dermatographism, a severe history of severe anaphylaxis, or if patients cannot stop their antihistamines for 48 hours. It is also possible to investigate allergy during acute episodes by searching with a blood test for mast cell tryptase, which is released from these cells during anaphylaxis. However, this must be done in the first 6 hours following allergen exposure. Basic principles in the management of allergy include avoidance of allergen, so via dietary modification in food allergies and avoidance of drugs in drug allergies, and the use of various different drugs. These include drugs that block mast cell activation, such as sodium chromoglycate, which stabilizes the mast cell membrane and is administered as a topical spray, antihistamines, which act as H1 receptor antagonists and therefore prevent some of the effects mediated by the histamine. Traditionally, these are thought to be very sedative, but some of the newer agents are less so. It's also important with antihistamines to know that they're not effective in asthma, as lung mast cells do not produce histamine. Corticosteroids may be used for their anti-inflammatory effects and act both on the early and late response. Newer agents, such as the leukotriene receptor antagonists, e.g. montelukast, are now also coming online for treatment of these problems. Bronchodilators can be useful, specifically in the acute setting or in patients with asthma. And the last therapy is allergen-specific immunotherapy, which is most useful in allergies due to single allergens, such as venom anaphylaxis and grass pollen allergy. The mechanism action here is that small amounts of the allergen are introduced to the patient with the hope of driving a Th1 response and IgG production, which eventually will neutralize allergens when they're introduced into the body, so that we won't be getting this IgE-mediated mast cell effect. This, however, has to be done in hospitals and carries a risk of severe anaphylaxis. So I'm now going to talk about anaphylaxis itself, which is really the allergic emergency and represents a severe systemic allergic reaction. Usually there is both skin and organ involvement. There will be respiratory difficulty caused by smooth muscle constriction in the airways and excess mucus production, often with laryngeal edema caused by excessive vascular permeability, as well as hypotension due to increased vascular permeability and leaking of fluid out of the intravascular compartment. There may also be GI involvement, causing nausea, diarrhea, vomiting, and characteristically an impending sense of doom. Skin involvement varies from a simple itch, erythema, right up to full-blown urticaria and angioedema. The most common cause of anaphylaxis is idiopathic. The next most common, foods, such as peanuts. The next, drugs, e.g. aspirin, IV contrast media. And then the least common, exercise and latex and insect bites. Management of anaphylaxis involves, firstly, airway, breathing, circulation. So you lie the patient down, elevate the legs to boost the venous return, secure the airway, give 100% oxygen, and then support the circulation through administration of fluids, 500 micrograms IM adrenaline, chlorpheniramine 10 milligrams IV, hydrocortisone 100 milligrams IV, and also bronchodilators if there's respiratory involvement. After recovery from the episode, it's important to refer sufferers to an allergy clinic to investigate the cause and to give them EpiPens, 300 micrograms in adults, 150 micrograms in children. So that really completes the most basic principles of allergic disease. I'm now going to go on to talk about some specific problems. First of all, food allergy. It's interesting to note that 20% of adults think that they have a food allergy, when in fact the actual prevalence is around 1 to 2%. We can split up adverse reactions due to food into food intolerances, such as food poisoning and enzyme deficiency, such as lactase, food aversion, such as fads and eating disorders, and food hypersensitivity, which may be type 1, an IgE-mediated reaction, type 3, such as dietary protein enteritis in children, and type 4, celiac disease. The most important type 1 foods to be aware of are peanuts, fish and shellfish, tree nuts, and sesame seeds. Management involves avoidance and giving the patient EpiPens for severe reactions. Next, I'm going to talk about two important skin manifestations of allergic disease. These are urticaria and angioedema. In urticaria, there is an itchy, red edema of cutaneous tissues, which may be split into two types. An acute, which is very common, usually idiopathic, but may be due to any other allergen which someone is allergic to. And chronic, where there are persistent wheals lasting for more than 6 weeks, plus or minus angioedema. Causes of chronic urticaria are, once again, 50% of the time idiopathic, but may be autoimmune or occur in response to various physical stimuli such as heat or cold, pressure or exercise. Acute urticaria is usually self-limiting and can be managed with allergen avoidance and antihistamines. Angioedema, acute non-itchy edema of the subcutaneous tissues, can occur in a number of the allergic diseases we've already described. However, it is a very important feature in C1 inhibitor deficiency, which is an autosomal dominant condition which is fairly rare. There are two types of this condition. In type 1, there is no C1 inhibitor at all. In type 2, the C1 inhibitor is non-functional. The lack of C1 inhibitor leads to unrestrained activation of the complement pathway, leading to C4 depletion and C3 depletion, and this explains why C1 inhibitor patients have low C4, C3. It also results in activation of kinin pathways, leading to increased levels of bradykinin and hence tissue swelling. Clinically, these patients present with recurrent angioedema and abdominal problems, such as pain, nausea, vomiting, etc., as well as swelling of the hands and the feet. In emergency situations, laryngeal edema may develop. Importantly, C1 inhibitor deficiency is characterized by the lack of urticaria. Often clinical episodes have triggers, which may be idiopathic or related to traumas, infections, or drugs. Lab features we've already spoken about a bit. There is a low C4, C3, and a specific assay can be done for the C1 inhibitor function, which shows it, of course, to be low. Treatment is with the anabolic steroid danazol, which increases C1 synthesis in the liver. Importantly, use of this drug is associated with liver problems, so an ultrasound is needed every 2 years. In severe attacks, C1 inhibitor concentrate is required. However, if this is not available, fresh frozen plasma can be used. So that completes the podcast on allergic disease and type 1 hypersensitivity reactions.